On a desk in a research office, two papers lie open side by side. The year is 2009. One is a listing of case reports stretching back more than a century, drawn from medical journals in Germany, Austria, England, and the United States, organized by condition, by date, by country of origin. The other is a draft of a paper that will eventually be published in the journal Death Studies, authored by Michael Naum and Bruce Grayson. Between the two documents, a pattern is visible that no single case file could have produced alone, a pattern that becomes clear only when the cases are arranged together, only when the repetition is allowed to speak in the aggregate rather than one account at a time. The pattern is this: patients who had lost the capacity for coherent thought and speech, some of them years before, some of them decades before, were returning to clarity in the final days before death. Not partially, not in fragments, returning to something that observers consistently described as genuine recognition, purposeful speech, and the specific quality of a person who was present in the way they had not been present for a very long time. Naum and Grayson gave this a name. They called it terminal lucidity. The definition they published was careful and bounded, the unexpected return of mental clarity and coherent communication in patients who had lost these capacities due to severe neurological or psychiatric illness occurring in proximity to death. The name was new. The phenomenon it described was not. The 83 cases assembled in that survey had not been collected from a single institution or a single country. They had been gathered from medical literature across more than a century of independent observation, reports filed by physicians in Germany in the early 19th century, case notes from Austrian psychiatric facilities in the later 1800s, accounts from British and American medical journals in the 20th century, clinical reports from hospice and palliative care settings in the years immediately preceding the 2009 paper. Naum had worked through this archive slowly and carefully, extracting cases that met consistent criteria, setting aside those that did not. The 83 that remained formed a body of evidence with a striking internal coherence. What the cases shared was not simply the fact of clarity appearing before death. What they shared was a specific cluster of conditions under which that clarity appeared. The patients documented in these reports had not been experiencing the ordinary fluctuations that accompany the early or middle stages of neurological decline. They had been in states of severe and stable cognitive deterioration measured in years, and in some cases in decades, deterioration that had progressed past the point where medical staff expected further change in either direction. They had lost verbal communication. They had lost the ability to recognize the people closest to them. They had been in the clinical language available to their physicians, absent in a way that had come to be accepted as permanent. And then, in the days or hours before death, something returned. The survey noted a temporal pattern that distinguished these episodes from the ordinary variability of disease. The majority of documented cases occurred within 1 to 7 days before the patient died. A significant subset occurred within hours of death itself. This timing was not the timing of a good day in a difficult illness, not the temporary improvement that can follow a change in hydration or medication or the time of day. The timing was specifically proximate to the end, close enough that in many cases the clarity was the last meaningful communication a patient ever had. A laminated chart on the wall of a memory care unit shows a patient's name and the date they last spoke coherently. The ink is slightly faded with age. The date it records is years in the past. Staff on the unit have worked their rotations, have transferred to other floors and returned, and the date on the chart has not changed. The expectation in that room, the quiet, accepted clinical expectation that has formed around years of consistent silence is that the date will not change. Terminal lucidity most frequently and most strikingly appears in patients with advanced Alzheimer's disease. The reason the contrast is most striking in Alzheimer's cases is partly biological and partly because of the specific way the disease progresses. Alzheimer's is not an illness of stable impairment. It moves. It takes over years and decades, the vocabulary first, then the recognition, then the ability to hold a conversation, then eventually the capacity for any voluntary communication at all. By the time a patient reaches the late stages that characterize the cases in Naumann Grayson's survey, the losses are not recent and not subtle. A family member who has been visiting for years has adapted over that time to a new relationship, a relationship defined by presence rather than exchange, by sitting beside rather than talking with, by learning not to expect the voice that was once familiar to respond in familiar ways. The return of that voice under these circumstances is not a small thing to witness. But terminal lucidity is distinguished in the clinical literature precisely because it is not equivalent to the ordinary fluctuations that families and staff do witness in dementia patients across the course of the illness. Those fluctuations are common. They are associated with identifiable causes, a change in infection status, a change in medication, improved hydration, the natural rhythm of the day that for some patients produces marginally better alertness in mornings or afternoons. These fluctuations occur in patients who still have some capacity for communication, some residual ability to recognize or respond, even if that residual ability is inconsistent. They are part of the ordinary clinical landscape of the disease. What Naum and Grayson's definition isolated, and what the 83 cases in the survey documented, was something different in kind. The patients in these reports had passed beyond the territory of ordinary fluctuation. They had been nonverbal, unrecognizing, and cognitively absent in a stable and enduring way. The months or years preceding the terminal lucidity episode contained no similar moments. The nurses who had cared for them had not seen this before. The family members who had visited had not experienced it. The episode arrived into a context where it was not expected, not predicted, and not explicable by the usual variables. There is a ward nurse in a corridor walking a familiar route past a room she passes 30 times in a shift. She has paused outside that door hundreds of times, listening out of professional habit for anything that requires attention. What she expects to hear most days is the ambient quiet of a room whose occupant does not produce sound in any organized way. What she hears instead, on this particular afternoon, is a voice, clear, unhurried, saying something coherent. She stops. The voice is not distressed. It is not the kind of sound that signals a medical emergency. It is the kind of sound she would expect from a patient who was having a conversation, a patient who was present, who was speaking to someone, who was finding words in sequence and using them with evident intention. And the room behind that door belongs to a patient who, according to everything in the chart, according to everything she has observed across months of care, does not do that, has not done that. The chart inside the room records the last date coherent speech was documented, and it is not a recent date. The ink on the notation is not fresh. She opens the door. This kind of moment, the pause in the corridor, the voice behind the expected silence, the opening of the door, appears across the case literature with enough consistency to qualify as a structural feature of the phenomenon, rather than an accident of individual reporting. It appears in the 19th century German records that Naum excavated from archives. It appears in 20th century case notes from British and American facilities. It appears in the qualitative testimony of palliative care nurses, writing in peer-reviewed journals in the years surrounding the 2009 paper. A researcher reading through 83 such moments in sequence, organized on a desk by condition and date, begins to recognize the shape before the sentence finishes. The pattern is familiar by the third page. By the 30th case, it has a weight that no single account could carry on its own. The death studies paper that Nam and Grayson published from that desk is not a long document by the standards of academic medicine. It is precise. It defines its terms carefully. It acknowledges the limitations of working from historical and retrospective case reports rather than prospectively collected data. It does not overstate what the 83 cases demonstrate. What it does is set them down in a named, organized, reproducible form, give them a vocabulary, a framework, a category in the literature that allows subsequent researchers to find them and build from them. Before 2009, the phenomenon existed in the medical record. It had always existed in the medical record. Physicians had been writing it down for at least 2 centuries. What it had lacked was a name that would allow anyone to search for it, to collect the scattered accounts into a single view, to see whether what one physician in Germany had observed in 1817 bore any resemblance to what a hospice nurse in Ohio had recorded in 1993. The name terminal lucidity gave researchers the means to ask that question with some precision. The answer drawn from the 83 cases assembled in 2009 and from the research that followed in subsequent years was that the resemblance was not coincidental. The pattern held. It held across countries and across more than a century of independent observation. It held across different underlying conditions, though Alzheimer's disease produced the largest and most consistent body of cases. It held in the specific timing, the proximity to death that distinguished these episodes from anything else in the clinical picture, and it held in the nature of the clarity itself, coherent speech, recognition of individuals, purposeful communication, the specific quality of presence that observers consistently found difficult to describe in purely clinical terms. Afternoon light falls through the window of a hospital room, lying warm across the blanket on the bed, across the hand of the man lying there. His daughter is sitting beside him. She has been sitting beside him in this room and rooms before it for 4 years. In that time, he has not spoken her name. He has not, as far as anyone can determine, recognized her face. The visits have continued because she continues them, because presence is something she can offer even when exchange is not possible. She knows the room, she knows the afternoon light, she knows the particular quality of the silence between them, which is not hostile silence and not indifferent silence, but the silence of being in a room with someone whose inner life has become, over years, unreachable. He turns his head, he looks at her, he says her name, not the name on her driver's license, but the name he had for her when she was small, the specific private name that belongs to the specific private history between them, the name that would only be known to someone who had been present in her childhood and had held it in memory for decades. He says that name, and then he asks about her children. He asks about them by their names. This is the clinical territory that the phrase terminal lucidity attempts to hold, not the ordinary movements of a difficult illness, not the manageable fluctuations that caregivers learn to read and navigate. Something that stands outside those categories, something that arrives in the days or hours before the end, in patients whose decline has been severe and stable, and produces in the people who witness it a quality of experience that is difficult to fit into the frameworks available. The journal Death Studies sits on a researcher's desk, slim and academic, open to the paper where Nam and Grayson assembled their 83 cases. The margins hold pencil annotations, a question mark beside one case, a cross-reference to another paper, a note about the underlying condition. The annotations are not skeptical, and they are not credulous. They are the marks of someone working carefully through evidence that is genuinely puzzling, trying to understand what the cases are telling them, trying to see whether the pattern holds under close examination. It does hold. That is the finding. After the annotations, after the cross-references, after the careful comparison of case against case, what the paper establishes is that the pattern is real, that across 83 accounts gathered from more than a century of independent medical observation, the same cluster of features appears with a consistency that warrants the name given to it, and that warrants the continued attention of researchers trying to understand what produces it. The question of what produces it is a different matter. The cases document that terminal lucidity occurs. They do not in themselves explain why. That gap between the documented pattern and a satisfying explanation is where the research currently sits, not from lack of effort or lack of interest, but because the phenomenon presents features that resist the standard tools of neurological investigation. The episodes are spontaneous. They are brief. They occur in settings where monitoring equipment is not optimized for capturing neural data. They occur in patients who are dying. These constraints are worth holding alongside the cases themselves. The 83 accounts in the 2009 survey are not the output of a controlled experiment. They are observations, careful observations, made by named physicians and nurses and family members, recorded in clinical notes and medical journals and institutional records over the course of more than a century. The observations are consistent. The explanation is not yet available. Both of those things are true at the same time, and the second does not invalidate the first. What the paper by Nam and Grayson accomplished, from its starting point in that research office in 2009, was to make the phenomenon visible to the literature in a way it had not been visible before. Cases that had been scattered across decades and countries and languages were gathered into a single frame. The pattern that had been invisible at the scale of individual accounts became visible at the scale of 83. The name that had not existed was given. The research field that would eventually form around the phenomenon had a foundation to build from. The afternoon light in the hospital room has shifted by now, moving further across the bed, warm against the wall. The daughter is still sitting. Her father's hand is in hers. He is asking about her children by name, asking about them with the ease of someone who has always known them, who has always held them in mind. And the room around them is exactly as it was before he spoke. The same furniture, the same equipment, the same quiet, and what has changed is something that the furniture and the equipment cannot measure. Across the facilities and hospices and long-term care units where the cases in the literature were witnessed, there are charts on walls and notations and records that mark the last date of coherent speech. Some of those dates are months in the past, some are years. The ink on some of them has faded. Staff who rotate through these units learn, over time, to organize their expectations around what the chart records, to understand the silence in a given room as the baseline, to approach without anticipating exchange. The notation on one such chart reads, "Last spoke, coherently," a date 3 years prior. The name above the notation belongs to a patient who, on the morning in question, was lying quietly in the room behind the door, as the patient had been lying for months, as the staff expected the patient to continue lying. The morning had been ordinary, the shift had been ordinary, The corridor was the same corridor it always was, with its familiar light and its familiar sounds and its familiar sequence of rooms. And then the patient said a name, not loudly, not in distress. Said it the way someone says a name when they see the person it belongs to, with recognition, with the weight of a specific relationship behind it. Said it into a room that had not expected to hear it, in a facility where the expectation of speech had faded with the years, in a voice that the staff member who heard it later described, in clinical notes, as clear. The research that Nam and Grayson assembled could not tell that staff member why the name was spoken. It could not offer a mechanism or a cause. What it could offer was the knowledge that the moment was not isolated, that it had been observed before, in other rooms, in other facilities, in other decades, by other people who had paused in corridors and opened doors and stood in the threshold trying to understand what they were hearing, that the pattern was documented, that the name for the pattern existed, that the question the moment raised was a genuine question, open and recorded and being held carefully in the literature, unresolved. The journal on the desk, the penciled annotations in the margins, the numbered list of 83 cases with their dates and conditions and observations, these are the material record of the moment's persistence across time. The cases go back more than a century. The pattern across all of them is the same. The clarity arrives close to death. It arrives in patients whose decline has been severe. It arrives after years of silence, in rooms where silence had become the understood condition. It arrives, and then within hours or days, the patient is gone. What the arrival means, what it says about the nature of what was lost during the years of decline, about what the brain was doing in those final hours, about the relationship between cognition and the physical structures that appear to underlie it. These are questions the research holds openly. They are questions being examined carefully and with genuine scientific interest by the researchers who followed Nam and Grayson into this territory. They are questions that have not been answered. The room is quiet. The afternoon light continues its slow movement across the bed. The daughter is still there, holding a hand in a hospital room that is exactly the same as it was an hour ago and entirely different. Outside, in the corridor, there is a chart on the wall. The chart records the date that coherent speech was last documented. The date is 3 years old. The ink is slightly faded. And in the room behind the door, a man who has not spoken a recognizable word in all that time has just asked his daughter by name about her children. The chart has not yet been updated. The notation in the margin of the journal remains a penciled question mark. The voice in the room is quiet again now, settling back into a stillness that the nurse in the corridor recognizes as the familiar stillness. But it was there. It was heard. It is in the record. The question of what it was remains open. The pattern of its appearing is documented. And somewhere in the archive, in the stack of 83 cases organized by condition and date on a researcher's desk in 2009, the same moment has been noted before, in the same careful clinical language, in the same state of being observed and held and not yet explained. The voice was clear. That is what the notes say. Clear, and then quiet, and then at rest. In the winter of 1817, in a city where the medical profession was still learning the habit of writing things down with precision, a German physician named Karl Berne sat at his writing desk and documented something he had witnessed in a patient who had, by any reasonable clinical measure, already gone beyond the reach of ordinary cognition. The room was quiet. The act of recording it was deliberate. He chose his words carefully because what he had observed did not fit the expected arc of the illness he had been following, and he was the kind of physician who believed that things which did not fit deserved to be written down rather than set aside. Berna's notes described the sudden appearance of mental clarity in a patient whose mind had been for a considerable period unreachable. The patient had communicated nothing coherent for a long time. The patient's condition had been severe and stable in its severity. And then, in the period before death, something had changed. Briefly, unmistakably, and without any intervention that Berna could account for. The patient had been present in a way they had not been present in a very long time. And then they had died. What Berna did next was the significant thing. He wrote it down. He did not conclude in his 1817 notes that he had witnessed something supernatural. He did not suggest that the laws governing the brain had been suspended. He recorded what he had observed in the careful, plain-spoken language of a physician who had learned that the first obligation of medical witness is accuracy, and that accuracy begins with setting down what actually happened before the mind begins to smooth the strangeness away. The case was entered into his records in the same matter-of-fact register as every other entry. That steadiness of hand, that refusal to dramatize, is part of what makes the document worth anything at all. Michael Naum, a researcher who would spend years working through the historical literature on pre-death lucidity, later identified Berna's 1817 writings as among the earliest systematic attempts to catalog what would eventually come to be known as terminal lucidity. Naum was not looking for the picturesque or the uncanny. He was doing the slow, unglamorous work of locating accounts that had been written in German in the early 19th century and that had, for various reasons of language, publication venue, and disciplinary drift, never made their way into the broader literature on consciousness and dying. Berna's notes were one such account. They were precise. They were consistent with accounts written by other physicians in other German-speaking cities across the decades that followed. And they had been sitting in the archive, patient as old paper always is, waiting for someone to find them. The archive, in cases like this, does a particular kind of work. It holds things across time in a way that individual memory cannot. A physician in early 19th century Leipzig observes something unusual in a patient and writes it down. Another physician in Vienna, a decade later, writes down something similar without any knowledge that the Leipzig observation exists. A third physician in Berlin adds his own account 20 years after that. None of these men knew the other's work. None of them was constructing a theory. Each was simply recording what had happened in front of him in the language of his training, at the desk in his consulting room or ward office, by whatever light was available. The archive collected all of these accounts across time without any one of them intending to contribute to a pattern. And then the pattern was there, waiting in the accumulated records of institutions and medical journals and personal case notes spread across the German-speaking world. Naum's work, undertaken nearly 2 centuries after Berna first put pen to paper, was the work of reading across that accumulated record. It required the kind of patience that archive research always requires, moving through documents in languages that had shifted their medical vocabulary considerably since the texts were written, identifying the consistent features in accounts that used different terminology and different diagnostic categories, following footnotes that led to other obscure journals in other institutional collections. The result, built out carefully over years, was a picture of the 19th century, quietly watching the same thing happen again and again in different rooms across different decades, and recording it each time with the same puzzled, attentive precision. Throughout the 1800s, German-speaking physicians produced scattered but independently consistent case reports of patients with severe mental illness or cognitive deterioration, exhibiting moments of mental clarity in the period before their deaths. The word scattered is important here. These accounts did not form a school of thought. They did not generate a formal debate in the medical literature of the time. They appeared in the records of psychiatric institutions, in the personal case notes of individual physicians, in the case sections of broader medical writings that were primarily concerned with other questions. They were not gathered into a single place and examined together. They were simply recorded, patient by patient, year by year, in the language of careful medical observation, and then filed. What Nanda found when he read through this distributed record was that the same core observation kept appearing: a patient who had been severely cognitively impaired, often for many years, who had ceased to communicate coherently, who had shown no signs of recognition or responsiveness for a long period, would, in the final days or hours of life, briefly recover something that the attending physician could only describe as their former mental presence. The clarity that appeared was not confused or fragmentary. It was, in case after case, described as coherent, purposeful, and recognizable. The person as they had been before the illness had taken them, beyond ordinary reach. The physicians who recorded these observations were not, by temperament or training, inclined toward mystical interpretation. The German medical tradition of the 19th century was empirical, institution-based, and committed to the documentation of observable phenomena as the foundation of reliable knowledge. What these physicians were doing when they wrote down these cases was not reaching for metaphysics. They were doing what their training told them to do with anything unexpected: observe it carefully, record it accurately, and leave it in the file for whoever came next. One of the cases that emerged from Nam's historical survey concerned a woman named Anna Katharina Emmer. The details of her case as they appear in the historical record are worth dwelling on, not because they are dramatic, but because they are so precisely documented, and because what is documented is genuinely difficult to account for in ordinary clinical terms. Emmer had lived in a state of severe mental incapacitation for a period estimated at approximately 3 to 4 decades. She had not communicated in any recognizable way during that time. Caregivers who had worked in the institution over the years had no expectation that she would speak or sing or demonstrate any kind of deliberate expressive behavior. She had been, for as long as anyone currently working in the institution could remember, beyond the reach of ordinary interaction. Her silence had become part of the institution's ordinary landscape, something that was no longer noted because it had not changed in so long that it had ceased to be a condition and had become simply a fact. In the hours before her death, Anna Katharina Emmer began to sing hymns. The account that survives in the historical record notes that the singing was coherent. It was not fragmented or confused. It followed the structure and melody of the hymns she sang with evident familiarity, the words in order, the melody intact, her voice clear and steady. Caregivers who heard her reported being stopped in their work by the sound. Some of them had never heard her produce a sustained, deliberate vocalization of any kind. The hymns were sung, as the account describes it, with evident joy, a quality of feeling that the observer found as striking as the cognitive capacity the singing demonstrated, and that the record preserves alongside the clinical observation because the observer apparently could not leave it out. She died shortly after. The account of Anna Katharina Emmer was preserved in a historical record that Nam located and cataloged during his survey of the early literature on pre-death lucidity. Its value, from the perspective of the researcher reading it nearly 2 centuries after it was written, lies not in what it proves, but in what it reports. A woman who had not communicated in decades, sang hymns clearly and with evident emotion in the hours before her death, in the presence of caregivers who recorded what they observed in the plain language of institutional notes. The account had been sitting in the archive for a very long time before anyone thought to look for it, alongside similar accounts from other rooms in other institutions across other decades. The act of looking alongside, of reading Berna's 1817 notes next to similar accounts from the 1830s and the 1850s and the 1870s, produces something that no single account produces on its own. It produces the sense of a pattern, not a theory, not an explanation, a pattern, the repeated observation across independent witnesses in independent institutional settings of the same phenomenon appearing under the same general conditions, a patient severely and stably impaired, a period of complete or near complete loss of communication, the approach of death, and then, briefly, a return of something that had been considered gone. Alexander Bathian, a cognitive scientist working at the International Academy of Philosophy in Liechtenstein, brought a different set of tools to this historical record than Nahm had brought. Where Nahm had been doing the work of the historian, moving through archives, locating texts, identifying the consistent features of accounts written in the medical language of a previous century, Bathian was doing the work of the systematic scientist, attempting to establish not just that the accounts existed and were consistent, but that they formed a robust enough evidentiary body to be taken seriously by contemporary researchers working on consciousness and dying. Bathian's 2018 systematic review drew on the same kind of broad base of material that Nahm had worked with: historical records, caregiver testimonies, clinical reports from multiple countries and multiple decades, and structured it according to the methodological standards of contemporary academic review. He was, in essence, doing for the modern research literature what Nahm had done for the historical record, bringing dispersed and independently generated observations together into a form that could be read as a coherent body of evidence rather than a collection of isolated anecdotes. What the review established, in the methodological terms that matter in the contemporary scientific literature, was that terminal lucidity was a recurring and cross-culturally documented phenomenon rather than an isolated curiosity. It appeared across different countries. It appeared across different medical conditions. It appeared in accounts generated by observers with no knowledge of each other's observations. It appeared in the 19th century and in the 20th. The specific clinical details varied from case to case, as one would expect from reports collected across a very long period of independent observation. The core pattern, the severity of prior impairment, the proximity to death, the quality of the clarity, did not. There is something particular about the kind of work that both Nahm and Bathiani were doing that is easy to underestimate when describing it in summary form. Reading through the archive to find these accounts is slow. The records are spread across many different kinds of institutional documents: medical journals, hospital ledgers, personal case notes, published memoirs, letters from physicians to colleagues, none of which were assembled with the idea that they would one day be read together as a body of evidence about a specific phenomenon. Finding them requires knowing what to look for, which in the early stages of the research means working from a description of what has been observed, rather than from an established diagnostic category that would give the researcher a reliable index term to search. A thick ledger book of patient records from a 19th century German psychiatric institution holds on most of its pages entries that have nothing to do with pre-death lucidity. The relevant entries are scattered through the record without any particular marking to distinguish them. Finding them means reading through entries that are unremarkable until they are not, reading through the standardized note about condition and behavior until the entry suddenly contains a notation that the patient, who has been listed as nonverbal and non-responsive for a decade or more, spoke clearly on a particular date, and that this date was within days of their death. The entry might occupy 3 or 4 lines in a ledger that runs to hundreds of pages. It might use a formulation that does not immediately declare itself as an instance of the phenomenon being sought. It is the kind of thing that requires patience and the willingness to read carefully and the capacity to be interested by something that does not announce its own significance. A shelf of these ledgers, bound in plain covers, sitting in a university archive in a German-speaking city, represents a particular kind of waiting. The observations are there. They have been there for a long time. The physicians who made them had no way to know that someone would eventually come looking for them with the specific purpose of reading them alongside each other. They wrote down what they saw because writing down what you see is what a careful physician does. The archive held it. The pattern that Name identified in these historical records, and that Bothiany later worked to establish in the terms of contemporary systematic review, held across more than a century of independent observation before either of them began their work. It held across physicians who had never heard of each other, writing in different decades, working in different institutions, recording their observations in the standard language of their time and place, and training. It held across different underlying conditions. It held across different countries. The consistency was not the result of any single researcher's organizing vision. It was there in the material, distributed across the archive, waiting to be read. The 2009 survey conducted by Nam and Bruce Grayson and published in the journal Death Studies brought this historical record into contact with the modern literature on terminal lucidity in a single organized document. The survey identified 83 case reports drawn from both historical and contemporary sources. These were arranged by condition, by date, by the severity of prior cognitive impairment, and by the proximity of the lucid episode to death. The list ran across more than a century of independent observation. The countries represented in the list included Germany, Austria, the United States, and others. The medical conditions represented ranged from severe psychiatric disorders to advanced dementia to meningitis-related brain injury. Reading down the column in the survey table, headed simply Condition Prior to Episode, the column showing entries like severe dementia, nonverbal, 7 years, or psychiatric institutionalization, no coherent speech, 3 decades, is an exercise in confronting the weight of what these cases have in common. Each entry represents a person. Each entry represents a physician or caregiver who wrote down what they saw. The column does not tell the full story of any individual case. It compresses each situation into a few words. But those few words, multiplied across 83 entries spanning more than a century in several countries, produce something that is hard to dismiss as coincidence or artifact. The column does not explain what happened. It simply shows what the condition was before the lucidity appeared. And what it shows, across case after case, is that the condition was severe and stable in its severity and long established, and then the lucidity appeared anyway. The 1817 writing desk in Carl Berna's room and the 20th century reading tables of Michael Nahm and Alexander Bethyan are part of the same long project. The project does not have a resolution to offer. It does not arrive at a conclusion that explains what has been observed. What it has, instead, is the record itself, compiled with care across 2 centuries, by people who understood that the first obligation of the person who witnesses something unusual is to write it down accurately, and the first obligation of the person who reads the record is to take what has been written seriously. The archive grows slowly, the way all careful records grow. One observation at a time, one entry at a time, each physician or caregiver adding their account to the accumulated file without knowing how many other accounts sit beside it or what pattern they collectively form. Nam read the file as a whole. Bathiai worked to establish what the whole file, read carefully and methodologically, could be said to demonstrate. What both of them found was the same pattern that Carl Berna had documented in 1817, without knowing that anyone else would ever document anything similar. The pattern of a mind returning, briefly and without explanation, in the last hours before it left entirely. There is a stillness to this kind of research that belongs to it specifically. It is not the stillness of a solved problem. It is the stillness of sitting with something that has been carefully and repeatedly observed, and that has not been satisfactorily accounted for. And that continues to be reported by people who have no theoretical investment in what they are reporting. Nurses who simply note in their clinical records that a patient who had not spoken in years spoke this morning. Physicians who annotate their case files with an observation that does not fit the expected disease course and deserves, they feel, to be recorded. Caregivers in institutions who describe what they heard coming from a room they expected to be silent. The ledger books on the shelf in the 19th century German psychiatric institution are, in their way, the most important objects in this story. Not because they contain dramatic revelations, because they contain accurate records. Because someone sat down at the end of the day and wrote down what had happened in the language of careful medical observation. And because that habit of careful recording meant that what happened was not lost and could be found again 2 centuries later by a researcher looking for exactly this kind of evidence, moving through exactly this kind of archive, with exactly this kind of patience. Nam's compiled list of 83 cases is in the end a record of witnesses. Each entry represents a person who was present in a room when something unexpected happened and who wrote it down. Each entry represents a patient whose final hours included something that the attending physician or caregiver found striking enough to record. The list stretches across more than a century. It crosses national boundaries. It spans conditions that were understood very differently in the 19th century than they are understood now. It includes cases documented by physicians who had no conceptual framework that could account for what they had seen, and cases documented by physicians who had every modern diagnostic tool available and still found the episodes they were recording resistant to easy explanation. What the list does not contain is an explanation. It contains observations. It contains the consistent features that Nam and Grayson identified across the whole range of cases: the severity of the prior impairment, the proximity to death, the quality of the clarity. It contains the accumulation of more than 100 years of careful, independent, professionally generated witness, and then it rests there on the page in the columns of the published table with all 83 entries arranged in orderly rows, and the question that runs underneath all of them still open. The question is not announced. It does not declare itself in the table or the accompanying paper. It is simply there in the structure of what the list records, the gap between the condition prior to the episode and the episode itself, the gap between what the disease had taken and what briefly returned, the gap that each physician who wrote one of these entries was circling, carefully and without conclusion, when they chose to record what they had observed rather than leave it unwritten. Carl Berna's room in 1817 was quiet when he wrote his notes. The act was unhurried. He was a physician doing what physicians do, setting down what he had seen in the language of medical record keeping, without performance, without certainty about what the observation meant. The record survived. The pattern accumulated across the decades that followed. And more than 2 centuries after Berna's pen moved across the page in that quiet room, the observation he wrote down, the sudden return of a mind that had been considered unreachable in a patient close to death, observed and recorded by a careful professional who did not know what to make of it and said so honestly, is still part of the file, still one of 83, still waiting, with the patience that only written records have, inside the larger accumulation of the same careful, open, unanswered witness. The shelf of ledger books, the annotated columns in the death studies table, the long run of independently observed, independently recorded instances of the same thing happening in different rooms across different decades and different countries, all of it quiet, all of it patient, all of it holding the same open question in the same careful, unhurried, deeply human language of writing something down because it happened and it seemed important, and perhaps someone would know what to do with it later. Nam's final list is not a solution. It is a collection of the same patient, precise, attentive act of witness performed by more than a century's worth of caregivers and clinicians, all of them describing, in the particular language of their time and training, the moment when a patient who had been considered beyond ordinary cognition briefly returned to it, were then as present, and then was gone, 83 times, across more than 100 years, across institutions in multiple countries, each entry written down in isolation, without knowledge that 82 other accounts would eventually be read alongside it, each entry forming, in combination with the others, a record whose consistency is both the most interesting thing about it and the thing for which, even now, no complete explanation has been offered. The ledger books sit on their shelf in the archive. The pages are old. The ink has faded in some of them, the entries still legible in the slanted script of a careful 19th century hand. One of those entries, somewhere in the long run of ordinary patient records, describes a person who had not spoken in years, and then, close to death, spoke clearly. The physician who wrote it probably believed, when he set it down, that it was unlikely to mean very much to anyone who read it later. He wrote it down anyway, and it turned out to be one more instance of the same pattern that would eventually be observed 82 other times, to 82 other rooms, across a century, and more of the same quiet, unresolved, carefully preserved witness. The pattern of a voice returning to someone who had been silent a long time, in the last hours before the silence became permanent. A hospice room holds a particular kind of quiet, not the quiet of an empty room or a room between uses, but the quiet of a room where everything that needs to happen has slowed down to its most essential pace. The chair pulled close to the bed, the window light changing through the afternoon, the sound of breathing, measured and familiar, something the family members in that room have learned to listen for without consciously listening. In a room like that, in a facility where the staff have long since stopped expecting anything to change, the stillness has a quality of settled acceptance. It has become the ground on which everything else rests. The woman in the bed had not spoken a recognizable word in 3 years. Her family knew this with the particular precision that comes from keeping track, not because they had marked it on a calendar, but because the absence had its own weight, accumulated over months that became years, each visit another layer of the same silence. Her diagnosis was Alzheimer's disease, late stage, and the clinical picture was consistent with what that diagnosis means at its most advanced. No reliable recognition of faces, no coherent verbal communication, no demonstration of memory for names or places, or the relationships that had once organized her life. The staff who cared for her did so with attention and care, but with no expectation of response in kind. The laminated sheet near the nursing station noted her status in shorthand that had not needed updating. The date of her last coherent speech was there, the ink slightly faded now. A number of years that had seemed remarkable when it was first recorded and had long since simply become the fact of her condition. Her son arrived on a Tuesday afternoon, the way he arrived most Tuesdays, with the particular combination of presence and preparation that characterizes a family member who has made peace with what a visit now means. He sat down. He spoke to her quietly, the way he had learned to speak in that room, not expecting reply, not performing for an audience, simply present in the way that presence is sometimes the only thing left to offer. The light from the window was low and warm. The room was still, and then she turned toward him, not reflexively, not with the vague, unfocused movement that was familiar, but with intention, and she said his name. This is the pattern that researchers in palliative care and neurology have been documenting, collecting, and attempting to understand for decades. It is not a single case. It is not a rare anomaly confined to one disease or one population. Across the full range of conditions in which severe cognitive impairment occurs, conditions that affect the brain through entirely different mechanisms, that produce different patterns of damage, that carry different prognoses and different timelines, the same event appears. A patient who has not spoken coherently for months or years speaks. A patient who has not recognized the faces of people they loved for longer than anyone can precisely remember looks at one of those faces and knows it. The episode is brief. It ends, and within hours or days, in the great majority of documented cases, the patient dies. The condition most frequently represented in the documented literature is Alzheimer's disease. This makes a certain sense in terms of the numbers. Alzheimer's is the most common cause of dementia globally, and it is also the condition in which the contrast between the period of established impairment and the terminal lucid episode is most likely to be noticed and recorded, because the prior decline is so long, so well documented, and so complete. The families of patients in the late stages of Alzheimer's have typically adapted over years to the absence of coherent speech, to the loss of recognition, to a form of being together that no longer includes the exchange of words in the way that exchange once worked. When that exchange returns, even briefly, even for minutes or hours, the departure from the established baseline is unmistakable. In documented cases involving late-stage Alzheimer's patients, the episodes that have been recorded in clinical notes and in caregiver accounts share a consistent texture. The patient who has not spoken in 2 years calls a family member by a childhood nickname, not a formal name, not a general greeting, but a specific and private name that belongs to a specific and private relationship. The patient who has not demonstrated episodic memory for the better part of a decade asks about grandchildren by name, asks about events in their lives, asks questions that require not just recognition, but retained knowledge of the world beyond the room. The patient who has not held a coherent exchange since a date that appears on their clinical chart simply begins to speak, unhurried and clear, as though the silence had been a pause rather than a permanent condition. What makes these episodes clinically distinct from the ordinary fluctuations that can occur across the course of Alzheimer's disease is a question that researchers and clinicians have considered carefully. Dementia symptoms do fluctuate. They can vary with the time of day, with hydration, with medication adjustments, with the presence of a concurrent infection, or its resolution. These fluctuations are well understood and routinely observed by clinical staff. They are not the same thing as what is being documented under the name terminal lucidity, because the patients in whom terminal lucidity is recorded have typically been beyond the range of ordinary fluctuation for a long time. Their impairment has not been variable. It has been stable and severe, at a level where the routine causes of symptom fluctuation no longer apply in the way they apply earlier in a disease course. The clarity that emerges near the end of life in these patients is not a return to a level last seen a few weeks ago. It is a return to a level last seen years before, in some cases more years than the clinical staff currently caring for the patient have been employed at the facility. Beyond Alzheimer's disease, the documented cases extend into territory that raises the paradox in sharper terms. The brain damage and meningitis-related cases, for instance, is not the diffuse progressive atrophy of Alzheimer's. It is structural and acute damage that can be located and measured on imaging, the result of inflammation and pressure, and the particular destruction that bacterial or viral infection can bring to neural tissue. Patients who have been left in minimally conscious or vegetative states following severe meningitis present a different clinical picture than dementia patients, and when terminal lucidity episodes have been noted in this population, the context is different in important ways. The damage that preceded the episode is not the gradual accumulation of protein plaques and cortical thinning. It is a discrete and documented injury, the kind that appears on scans as absence rather than deterioration. Cases of this kind are described in the palliative care literature without resolution, noted, filed, held as documented events that do not fit comfortably within standard accounts of how function relates to structure in the injured brain. A patient whose brain imaging shows extensive damage in regions associated with language and memory does not, according to the straightforward reading of those images, have access to the function those regions once supported. The images do not change in the hours before such a patient speaks. The damage is where it was, and yet, across a body of observed cases, the speech comes. The meningitis cases are among those that researchers in the field cite when discussing why terminal lucidity resists easy explanation. The Alzheimer's cases can be complicated by the argument, which will be taken up more fully by those working on neurological hypotheses, that some function may persist in Alzheimer's even when it is not expressed, that the relationship between the loss of tissue and the loss of function is not always as direct as it appears. That argument has more difficulty accounting for patients whose brain damage is structural and well mapped. For those patients, the gap between the observed damage and the observed behavior is harder to bridge with available frameworks, and the case reports sit in the literature with that gap unaddressed. Primary brain tumors represent another context in which terminal lucidity has been observed and recorded. Glioblastoma multiforme, the most aggressive form of primary brain tumor, occupies particular territory in this regard because its progression is so thoroughly documented. Patients with glioblastoma are typically under close imaging surveillance. Their clinical status is monitored frequently, and the deterioration of their cognitive function when it occurs is tracked against a detailed prior record. When palliative care physicians working with these patients have noted episodes of increased alertness and coherent communication in the final days of life, the observations occur against a background of considerable clinical specificity. The patient's cognitive status 3 weeks ago, 2 weeks ago, last week is part of the record. The imaging showing the location and extent of the tumor is part of the record. The notation of the lucid episode, made by a clinician who has that record at hand, carries a particular kind of weight. Families of patients with glioblastoma who have reported these episodes describe the experience in terms that recur across accounts: the patient more present than they have been in months, the conversation more coherent, the recognition more precise. Palliative care physicians, reviewing these reports alongside the clinical documentation, have noted the timing. The episodes tend to occur in the final days, after a period during which cognitive function had been declining. The patient who seemed more distant with each passing week was in the period immediately before death, more there. That pattern appears across accounts from different families, different facilities, different countries, and different clinicians who had no contact with one another when they made their observations. The context of metastatic cancer spread to the brain produces a similar paradox. In metastatic disease, tumor deposits can be located in specific regions of the brain, producing cognitive effects that correspond to the functions those regions support. Memory difficulties, language impairments, changes in personality, and executive function, depending on where the lesions have settled. The functional impairments in this population are not diffuse in the way Alzheimer's effects are diffuse. They have addresses. The lesion affecting language comprehension is in a particular place. The lesion affecting memory retrieval is somewhere else. When a patient with several such lesions demonstrates, briefly and near the end of life, a return of the functions those lesions should be suppressing, the case does not resolve easily against the map of their own imaging. There is a palliative care ward that could stand for any of the places where these observations have been made: a ward at night, the overhead lights dim to the lower setting that signals the shift into the quieter hours, the nursing station staffed by the people who have learned the rhythms of the unit and the particular needs of each patient on it. A whiteboard near the station carries the room numbers and diagnoses in the shorthand of clinical practice. One entry reads, in abbreviated form, the equivalent of what the full chart elaborates: a stage 4 tumor, nonverbal for a period of weeks. The staff who pass that whiteboard know what it means. They have cared for this patient through the progression that brought the chart to this notation. They are not expecting anything from the room at the end of the corridor to be different tonight than it was last night. This is the setting in which the observations in the formal literature were made, not in research conditions, not with equipment calibrated to capture the event. In the ordinary course of clinical care, by people who were not watching for something unusual, who were doing what they always did in these rooms at this hour, and who found that the room had changed while they were not watching for it to change. The psychiatric illness cases form a distinct strand within the documented literature, and in some ways the oldest strand. Before Alzheimer's disease was named and understood, before brain tumors were operable or even consistently diagnosed, the patients most likely to be found in institutional care for extended periods with severe cognitive and communicative impairment were those with major psychiatric illnesses, schizophrenia, severe psychotic disorders, conditions that produced profound withdrawal from comprehensible speech and social interaction, sometimes for decades. The institutions that housed these patients in the 19th and early 20th centuries kept records, and those records, combed through by researchers including Nam in the process of building the historical case literature, contain accounts of the same pattern. A patient who had not communicated coherently for a long time and who was not expected to communicate coherently again, doing exactly that in the period before their death. These cases carry the weight of their historical context. The diagnostic categories of earlier centuries do not map neatly onto modern psychiatry. The conditions labeled and institutionalized in 19th century European medical practice, included an uncertain range of conditions that would be understood and categorized differently today. But what the records document, stripped of the diagnostic framework of their period, is consistent with what later observers would document in patients with more precisely understood conditions: severe impairment, stable over a long period, followed by a brief episode of unexpected clarity near the end of life. The consistency is what researchers in the field keep returning to. Not the explanation, there is no established explanation, but the consistency of the pattern across time, across populations, across conditions, whose mechanisms are entirely different from one another. Patients with vascular dementia and stroke-related cognitive impairment represent a somewhat different profile from the Alzheimer's population because the damage in vascular dementia is discrete and focal in a way that Alzheimer's atrophy is not. A stroke creates a defined lesion. Its location determines its effects. Rehabilitation clinicians work with the specificity of that damage. The functions that are affected correspond to the anatomy that is involved, and recovery, where it occurs, follows patterns that can be traced against the map of the original injury. When terminal lucidity has been noted in patients with vascular dementia or post-stroke cognitive impairment, the observations have typically been made by nursing staff rather than appearing in formal research publications. Because the systematic collection of cases in this population is less developed than it is for Alzheimer's disease, the formal literature here is thinner, and that thinness is itself a data point of a kind. It does not mean the episodes are less common. It may mean they are less likely to be recognized as the same phenomenon, or less likely to be reported in the publications that have built the Alzheimer's case literature. Nurses working in stroke rehabilitation and palliative care have described patients who demonstrated unexpected coherence near the end of life, patients who had been nonverbal for a period of weeks or months, and who, in their final days, briefly returned to functional speech. These accounts circulate in the qualitative nursing literature and in caregiver testimonies. They wait for the same systematic collection that the Alzheimer's population has begun to receive. There is an image that belongs somewhere in any careful account of how terminal lucidity sits within stroke-related impairment, a chart on a ward, the kind of chart that records daily status across the admitted period, with a column noting verbal communication that has been marked consistently for 60 days, with the notation that indicates none. The entries accumulate without variation, not because the nursing staff stopped paying attention, but because there was nothing to note. This is a careful chart. It is the work of people attending to this patient across 2 months of clinical care. And then, near the bottom of the final page, in a different ink and a slightly different hand, the notation that reads, in the plain language of clinical record keeping, that the patient spoke this morning, that the patient asked for her sister by name. That notation sits at the bottom of that page, the way a stone sits at the bottom of still water. It does not change the entries above it. It does not explain itself. It simply is there in the record, dated and timed, and written in the handwriting of someone who was present when it happened. The range of conditions in which these episodes have been documented: Alzheimer's disease, meningitis-related brain injury, primary brain tumors, metastatic cancer, severe psychiatric illness, vascular dementia, and stroke, spans almost every major pathway through which the brain can be significantly and durably impaired. They share very little in terms of mechanism. Alzheimer's operates through one process, meningitis through another, glioblastoma through a third. Vascular dementia and major psychiatric illness involve different tissues, different timelines, different functional consequences. What they share is the documented pattern at the end, the impairment established and stable, the speech or recognition absent for a period that clinical staff and family members can measure in months or years, and then the brief return.
Our researchers in this area are careful about what they claim this means. The cases are documented, the pattern is consistent. The pattern has been consistent across more than a century of independent observers. What the pattern means, what it reveals about the relationship between brain function and cognitive experience, what it suggests about the mechanisms of either the impairment or the return, those questions are held open because the evidence that would allow them to be answered does not yet exist.
The observations accumulate, the accounts are collected and compared, the pattern persists, and the gap between the pattern and any adequate explanation of it remains exactly where it has been since the first careful observer wrote down what they saw. The woman with Alzheimer's who turned toward her son on that Tuesday afternoon and said his name was not speaking in a context that clinical observation had prepared anyone in that room to expect. The staff who cared for her knew her chart. They knew the date of her last coherent speech, the way you know a number that has been significant for long enough to become part of the furniture of daily awareness. They did not expect her voice to return. When it did, what they heard was not miraculous or alarming or impossible in any way that required a different response from the care they were already giving. It was simply clear. Her voice was clear. His name was clear. The room was quiet around it, the afternoon light still coming through the window, and she had said something that by all established expectations she should not have been able to say, and now the room held that too, alongside everything else it already held. In the palliative care literature, accounts like this one are no longer treated as anomalies that require individual explanation. They are treated as instances of a documented pattern, a pattern that appears across conditions, across populations, across the full range of ways in which the brain can be severely and durably impaired. The pattern is real. The cases are real. The clinical observers who noted them were real professionals, working in real facilities, recording what they witnessed in the plain language of clinical practice. What the pattern means has not been established. What mechanism underlies it has not been identified. What it reveals about the relationship between brain structure and cognitive function has not been resolved. The questions remain open in the way that genuine questions remain open, not for lack of attention, but because the phenomenon resists the explanations that have so far been offered for it, and because the evidence that would allow a more definitive account has not yet been collected. The cases continue to be observed. The accounts continue to be filed. The pattern continues to appear in Alzheimer's wards and stroke units, in palliative care facilities, in hospices, in the rooms where the most careful kind of attention is paid to people who are approaching the end of life, where every change is noted and nothing is left unrecorded that can be recorded. A stroke ward chart 60 days long, every entry in that column reading the same, and at the bottom of the final page, in a slightly different hand, the notation that the patient spoke, that she asked for her sister, that the question of her condition, which had seemed entirely settled by 2 months of documented nonverbal status, turned out to still have something in it that had not yet been fully read. The chart is still there, in whatever archive holds the records of that ward, with its 60 days of flat notation and the one line at the end that sits differently from all the lines above it. The brain damage that preceded that line was measured. It was mapped. It was documented in imaging that shows, in the clear language of medical imaging, exactly where the damage is and what functions it has disrupted. The notation at the bottom of the chart does not change what the imaging shows. It simply rests alongside it, in the same record, an observation of what happened placed next to a documentation of why it could not have happened in the way that it did, both true, both carefully recorded, and the distance between them still unresolved. In a laboratory at the University of Michigan in 2013, a team of researchers was watching a monitor. The experiment was a study of the dying brain, and the subjects were rats in the final moments of cardiac arrest. The researchers expected the EEG readings to show what most physiological intuition would predict: a gradual flattening, a reduction, the signal fading as the brain lost its supply of oxygenated blood, and the organized electrical activity of a living nervous system quieted toward stillness. What the monitor showed instead was something that moved in the opposite direction. At the moment of cardiac arrest, the EEG recordings did not descend, they rose. The gamma wave activity, the high-frequency oscillations associated with conscious perception and coordinated neural processing, surged briefly upward, more organized and more intense than it had been during the waking state that preceded it. The line went the wrong way, and then it went flat. The lead researcher, Jimo Borjigan, was a neuroscientist who had spent years studying the biochemistry of the brain, and the result her team published in the Proceedings of the National Academy of Sciences that year was precise about what had been measured and careful about what it could be taken to mean. The study documented the electrical surge. It noted that the gamma wave increase appeared within 30 seconds of cardiac arrest. It observed that the coherence of the activity, the degree to which different regions of the brain were oscillating in coordinated patterns, increased rather than decreased in those final moments. The paper offered the finding as a contribution to the understanding of near-death experience, noting that organized neural activity in the dying brain might account for certain features of what people report in those circumstances. What the paper did not claim was that the finding explained terminal lucidity. What it could not claim was that a surge measured in rats under controlled laboratory conditions translated in any direct way to the experience of a human patient in a hospice room who had not spoken a coherent word in 3 years. The distance between those two things was real, and the researchers said so, and the finding remained on the table. Interesting, carefully documented, and not yet connected to anything by more than a thread of hypothesis. The reason that thread matters is not that it resolves the question. It is that it begins to sketch a direction. The brain in the final phase of dying, at least in this model, does not simply shut down like a light switched off. It does something else first. It flares. And if that flaring is real, if it holds across species and conditions, and represents something genuine about the dying nervous system rather than an artifact of the experimental protocol, then the question becomes whether a human brain, in the hours before death, might experience its own version of that surge, not a metaphorical surge, not a spiritual one, a biochemical, electrical, measurable event that briefly restores something that had appeared to be gone. The data from Borjigan's laboratory cannot answer this. No data currently can. But the direction of the question became, with the publication of that study, a little more concrete than it had been the day before. The hypotheses that researchers have proposed for terminal lucidity are several, and they do not agree with each other, and none of them has been tested in a way that settles the matter. This is not a failure of scientific attention. It is a consequence of where the episodes occur, when they occur, and how briefly they last. A terminal lucidity episode takes place in a hospice room or a palliative care ward in a patient whose body is already in the final phase of dying. It lasts, in documented cases, anywhere from a few minutes to a few hours. It arrives without warning. It ends, and then the patient dies, typically within hours, or at most a day or two. No one has yet placed a patient experiencing terminal lucidity inside a functional MRI machine. No one has collected a real-time PET scan of a brain during one of these episodes. The gap between the technology and the event is not a narrow one, and the gap is where all the most interesting questions currently live. One of the hypotheses that researchers have put forward involves the body's stress hormones. The dying process is, among other things, a physiological crisis, and physiological crises activate the systems the body uses to respond to acute threat. Cortisol and related hormones rise. Adrenaline may surge. In acute situations, a sudden shock, a moment of danger, these hormones can produce a rapid sharpening of attention and a heightened clarity of perception. The hypothesis is that something similar might happen at the edge of dying, a hormonal surge that temporarily promotes arousal, briefly improves synaptic communication, and produces a window of something that looks like the mental clarity the patient had lost. The logic is not unreasonable. The problem is the context. Sustained high levels of cortisol are, in most circumstances, associated not with cognitive enhancement, but with cognitive damage. The stress response that sharpens attention in a moment of acute crisis is a different thing from the hormonal environment of a body that has been dying slowly for weeks. Whether a dying brain responds to its final hormonal shifts with something like arousal, or whether that particular mechanism is available at that particular stage of the process, is a question that has not been answered. The hypothesis exists. The evidence for it, in this specific context, does not yet. A second line of thinking runs in a direction that is, in some ways, even more counterintuitive. It begins not with what the dying brain might be gaining in its final hours, but with what it might be losing. Specifically, inhibition. The brain regulates its own activity through a complex system of inhibitory circuits, neural mechanisms that suppress certain kinds of activation and keep the overall system from running at a kind of unconstrained, unmodulated intensity. These inhibitory systems require energy and functional neural tissue to operate. In conditions like Alzheimer's disease, the progressive degradation of brain tissue damages many things, and one of the things it damages, over time, is the infrastructure of inhibitory control. The synaptic disinhibition hypothesis proposes that as the dying process proceeds and inhibitory circuits finally fail, suppressed cognitive function might be briefly released, not restored in the sense of rebuilding what was destroyed, but released in the sense of removing whatever was holding it back. The implication is a significant one. It suggests that in some patients with advanced Alzheimer's disease, some degree of preserved cognitive function might exist in a state of active suppression rather than complete destruction, and that terminal lucidity might represent a brief lifting of that suppression in the body's final hours. This hypothesis has the appeal of a mechanism that moves in a direction consistent with what is observed, something that had been there, unavailable, becoming briefly available again. It also has the problem of all hypotheses in this area, which is that it has not been directly tested in dying patients, and the architecture of the suppression it proposes, if it exists, has not been mapped in human brain tissue at the relevant stage of disease progression. The third direction involves neurochemistry in a more targeted way. The cholinergic system, the network of neurons that use acetylcholine as their primary signaling molecule, plays a central role in attention, memory, and the kinds of cognitive function that degrade most visibly in Alzheimer's disease. The relationship is well established. The deficiency of acetylcholine in the Alzheimer's brain is not a hypothesis. It is one of the most reliably documented features of the disease and the drugs most commonly prescribed to slow cognitive decline in Alzheimer's patients work, to the extent they work at all, by inhibiting the enzyme that breaks acetylcholine down. The hypothesis applied to terminal lucidity is that the dying process might trigger a release of endogenous acetylcholine, the brain's own stored supply, in a quantity and concentration that temporarily compensates for the deficiency that has been driving cognitive symptoms for years. The mechanism, if it exists, would be a kind of final pharmacological event, the brain drawing on a reservoir of its own chemistry in a way it has not done for years. It is a hypothesis with a clear internal logic, specific enough to be tested in principle and untested in practice, because collecting the necessary biochemical data from a dying human brain in the moment of a terminal lucidity episode is not something current research methods can accomplish without causing harm. Each of these hypotheses has a different point of origin and a different central claim, and they do not resolve into a single picture. It is possible that more than one of them is partially correct. It is possible that different cases of terminal lucidity in different disease contexts involve different underlying mechanisms. It is possible that none of the mechanisms currently proposed accounts for the full range of what has been documented. A neurologist standing at a lightbox in a hospital corridor holding a post-mortem brain scan from a patient known to have experienced terminal lucidity in the final hours of advanced Alzheimer's disease is looking at an image that shows the accumulated structural damage of years, the atrophy, the lesion patterns, the physical record of what the disease did. The scan offers no explanation for the conversation the patient's family reported the night before. The hypothesis says inhibitory failure. The hypothesis says cortisol. The hypothesis says acetylcholine. The scan says nothing. It holds the question the same way it has held it since the episode was first reported by the nursing staff, open, documented, and as yet without an answer that the evidence fully supports. The whiteboard in a university neuroscience department might have 3 competing hypotheses written in different colors, each one underlined, each one followed by a question mark. This is not a failure. In a field where the phenomenon itself is documented and the mechanism is not, a whiteboard with honest question marks is the appropriate record of where things stand. What researchers can agree on is that terminal lucidity exists as a clinical phenomenon, that people who have been nonverbal and cognitively absent for years sometimes speak clearly in the hours before they die, that this has been witnessed by professionals across a wide range of settings and disease contexts, and that its existence requires an explanation. What they cannot yet agree on is what the explanation is. The question marks are not placeholders for a forthcoming answer. They are the current state of knowledge, held precisely and without apology. The Borgigan study returns here not as proof, but as a frame. What it showed in rats, a brief surge of organized electrical activity at the moment the global system began to fail, is a finding that has not been replicated in humans under equivalent conditions, and that raises its own questions about interpretation. The gamma wave coherence the study measured could mean several things, and researchers have not agreed on which interpretation is most plausible. Some have read it as evidence that the dying brain produces organized conscious experience in its final moments, experience that might account for features of near-death reports. Others have noted that the same pattern could be an epiphenomenon, an artifact of the disinhibition process. Neurons firing in a coordinated pattern, not because they are supporting conscious experience, but because the regulatory systems that would ordinarily modulate their activity have already gone. The finding does not resolve which reading is correct. It does demonstrate that the dying brain, at least in this model, is doing something measurable and organized at the very moment when its systems are collapsing, and that the collapse is not simply a uniform fading, but something with more internal structure, than that image suggests. There is a palliative care ward somewhere in this picture, quiet at 3 in the morning. The overhead lights are low. A patient has been in the final stage of Alzheimer's for 4 years and has not spoken a coherent sentence in that time. The monitoring equipment at her bedside continues its slow, unchanged rhythm, heart rate, oxygen saturation, the numbers that have been gradually shifting over the past week in the ways that palliative care nurses recognize. The family has been called. They are in the room. And at some point in the night, she begins to talk. Not in the way she has occasionally made sounds in recent months, vocalizations without directed meaning, fragments that did not cohere into words. She talks. She addresses her daughter by the name she called her as a child. She asks about a grandchild. She says something that the family will later describe as a kind of goodbye, though the word she uses is not that word. It is something more specific, more her own. The monitoring equipment continues its unchanged rhythm through all of this. Whatever is happening in her brain, whatever mechanism has briefly restored access to language and recognition and the particular history of her relationships, it is not visible in the numbers on the screen. The vital signs show a dying woman. The voice in the room is something else. This gap between what the instruments can measure and what is being reported from inside the room is where terminal lucidity lives as a scientific problem. The instruments are not wrong. The vital signs of a person in the final hours of advanced Alzheimer's look the way they look, and the brain damage documented in post-mortem studies of Alzheimer's patients is real and extensive and consistent. The tissue loss is structural and measurable. The cholinergic deficit is biochemically established. None of that is in dispute. What is in dispute, or more precisely, what is unresolved, is how a brain in that condition is able, even briefly, to do what witnesses consistently report it doing. The research cannot currently bridge this gap because the bridge would require collecting data that current tools cannot collect from human patients in the relevant conditions. A prospective study with appropriate neuroimaging would require placing dying hospice patients in MRI scanners on the chance that a terminal lucidity episode might occur during the scan window. The ethical obstacles alone are sufficient to explain why this has not been done. The practical ones compound the problem further. The episodes are brief and unpredictable. They cannot be scheduled. What researchers have done instead is work from the data that is available: post-mortem studies, caregiver and family accounts, clinical case reports, historical records, and the accumulating evidence of surveys like Bathyan's that document how widely the phenomenon is observed by healthcare professionals across different disease populations and care settings. From this data, they can establish that the phenomenon is real and consistent. They can establish that it follows patterns that are not explained by ordinary fluctuation in disease symptoms. They can propose mechanisms that are physiologically plausible and consistent with some of what is known about the dying brain. What they cannot do is confirm any of those mechanisms through direct observation, because the direct observation has not been possible. The question of whether it will ever become possible is genuinely open. Some researchers have proposed developing less invasive monitoring protocols, continuous EEG recording in hospice patients, for example, which would not require moving patients and would capture neural activity continuously over a period of days, allowing analysis of any episode that occurred. This approach has limitations. EEG measures surface electrical activity with limited spatial resolution and cannot capture the full picture of what is happening in deeper brain structures. But it would be something. It would be a record. If a terminal lucidity episode occurred during a period of continuous EEG monitoring, the data captured might at least narrow the range of plausible mechanisms by showing what the surface electrical activity looked like during the episode compared to the baseline that preceded it. Whether such a study has been conducted and whether its results have been published in a form that advances the question is a matter the current literature addresses only in proposals and suggestions rather than in completed findings. A researcher's screen, late in a quiet office, might show an abstract in a search field. The abstract describes a proposed protocol for continuous neurophysiological monitoring in palliative care patients. The final line reads, "No prospective neuroimaging data exists for terminal lucidity episodes." The cursor blinks beneath it. The search has found the edge of what the literature currently holds, and the edge is that sentence, and beyond it is the part of the map that has not been filled in. This is not unusual in science. Many phenomena that are well documented and clinically recognized have not yet been explained at the level of mechanism. The gap between the documented event and the mechanistic account is a gap that research programs exist to close. In the case of terminal lucidity, the gap is wider than usual because the nature of the event makes it resistant to the standard methods of investigation, and the population in whom it occurs is not a population that can be subjected to the full range of neuroscientific protocols without serious ethical cost. The synaptic disinhibition hypothesis deserves a moment of additional attention because it has a feature the others do not. It does not require the dying brain to gain something it has lost. It requires only that it lose something it has been using to suppress what was preserved. This is a smaller claim in one sense. It does not ask the damaged brain to rebuild or regenerate, only to release. But it is a significant claim in another sense, because it implies that in at least some cases of severe cognitive impairment, some degree of cognitive capacity is preserved but inaccessible rather than destroyed. Researchers who work with Alzheimer's patients will note that this question, what is preserved and what is destroyed, is one of the active areas of inquiry in the disease. The evidence from some Alzheimer's research suggests that the brain has considerable capacity for compensation and redundancy, and that the clinical presentation of cognitive loss may not always map directly onto the extent of tissue damage in a simple linear way. If some cognitive architecture survives in a form that is functionally suppressed rather than structurally absent, the disinhibition hypothesis gives that architecture a way to briefly express itself at the end. The neuroscience needed to confirm or refute this in the specific context of terminal lucidity does not yet exist. The hypothesis is on the whiteboard, underlined, followed by a question mark. What the Borgigan data added to this picture was not a mechanism, it was a direction. It suggested that the dying brain, at a biochemical and electrical level, does something in its final period that is not simply a reduction of what it was doing before. The rats in the University of Michigan laboratory showed organized, coherent, high-frequency activity at the very moment their global physiology was failing. Whether this represents a generalizable feature of the dying nervous system, whether it holds in human brains, whether it holds in the brains of patients with the kind of extensive structural damage seen in advanced Alzheimer's or glioblastoma or meningitis-related injury, none of this is established. The study is a finding in a model system, and the distance between a model system and a specific clinical phenomenon in a human patient is a distance that science closes carefully, one study at a time, and has not yet closed in this case. The empty scanner room is worth sitting with for a moment. It is not a figure of speech. Somewhere in a medical facility equipped for neuroimaging, A functional MRI machine is calibrated and ready. It is a substantial piece of equipment, a large circular bore, a strong magnetic field, the infrastructure to detect minute changes in blood oxygenation across different regions of the brain in near real time. It can, in a patient who is conscious and cooperative and physically stable enough to lie still inside it, produce a detailed map of which areas of the brain are most active during different kinds of cognitive tasks. It has been used to study memory, attention, language, perception, emotion. It has been used to study the brains of people with Alzheimer's disease, comparing patients with healthy controls and tracking the progression of the disease across years of longitudinal study. It is a powerful and precise instrument for the specific set of questions it is designed to answer. The hospice ward where a terminal lucidity episode might occur tonight is down a corridor and somewhere else entirely, inaccessible to the machine by reason of what the patients there are and where they are and what is happening to them. The machine is ready. The episodes are not reachable by it. That distance, physical, ethical, practical, is the distance inside which all the current hypotheses sit, unconfirmed and genuinely open. This is what a genuinely open scientific question looks like from the inside. It looks like a researcher reading through post-mortem brain scans and finding nothing that explains the family's account. It looks like a proposed EEG monitoring protocol that has not yet been funded or completed. It looks like 3 hypotheses on a whiteboard, each with a question mark. It looks like the Borgigan findings sitting in the literature, cited in papers about terminal lucidity, not because it proves anything about the phenomenon, but because it establishes that the dying brain, in at least one model, does something unexpected and measurable in its final period, and that this finding is at least consistent with the existence of a brief window of organized neural activity near the end of life. Consistent with, not explanatory of. The language is careful because the evidence requires it to be. A palliative care physician who has been working in hospice settings for 20 years might describe the problem this way. The phenomenon arrives before anyone is ready for it. The monitoring that would be needed to capture it cannot be set up in advance because no one knows which patients will experience it or when. The equipment that would yield the most useful data is equipment the patients cannot reasonably access. The episodes end and the patients die, and the most the researchers can do is collect accounts from the people who were in the room, analyze the existing medical records, and work backward from what was observed toward what might account for it. This is not a failure of scientific method. It is the method working as well as it can under the constraints of the situation. It is just that the constraints are significant, and the question is patient, and the gap between the documented event and the mechanistic explanation has not closed appreciably in the years since terminal lucidity was formally named. Gimo Borgigan, in the years after the 2013 publication, continued to work on the neuroscience of the dying process. The question she was pursuing, what the brain does in its final moments, and what that might mean for our understanding of consciousness and experience, was not one that her rat study had answered, and she did not claim that it had. What the study had done was shift the frame slightly. The dying brain was not simply a diminishing system. It was a system doing something specific and organized in its final phase, something that looked, on the EEG readout, like an increase in a kind of coordinated activity that neuroscientists associate with conscious processing. Whether that activity is conscious processing, whether it represents experience, perception, the specific cognitive clarity that terminal lucidity witnesses describe, is a question that the EEG readout alone cannot settle. Because the readout shows electrical patterns, and the question asks about experience. And the bridge between those two things is the bridge that neuroscience has been working to build for a great deal longer than terminal lucidity has been formally studied. The corridor outside the palliative care ward is quiet at this hour. The doors are closed. Behind one of them, a patient whose chart records 4 years of nonverbal status is breathing slowly and steadily. The nursing staff have noted in recent days the signs they have learned to recognize as the body moving toward its final hours. The family has been called. The monitoring equipment is present and running. No neuroimaging protocol is in place. No EEG leads are attached. Whatever happens in the next hours will be witnessed by the people in the room, recorded afterward in the clinical notes, and added, if anyone thinks to report it, to the accumulating literature of terminal lucidity cases. It will not produce data of the kind that tests a mechanism. It will produce a testimony, a carefully dated account of what was observed, and that account will sit alongside the other accounts in the growing file of documented episodes, waiting for the research methods that might eventually make sense of it. The scanner room down the corridor holds its calibration. The field is strong and steady. The console shows a standby screen, the cursor blinking at a quiet pace in the lower left corner, the machine ready for a study that is not scheduled tonight and has not yet been designed. In the distance, through walls and along corridors, and past the nurse's station with its familiar sounds, the phenomenon that has not been scanned and has not been biochemically captured and has not been explained in any way that the evidence fully supports, continues to occur in the way that it has continued to occur for as long as there have been people in the final phase of dying to witness it and others to stay in the room and write down what they saw. The empty scanner room does not resolve the question. It simply marks its location, the specific, physical, quiet distance between the machine and the ward, between the measurement and the thing to be measured, between the hypothesis on the whiteboard and the voice that was heard through the door. That distance is not a silence. It is the space the research has not yet crossed. It holds, in the way that genuinely open things hold, without weight and without urgency, patient as the question itself, as the still air of a room built for precision, waiting. In a hospital room in the autumn of 2007, the monitors above Victor's bed were reading the same numbers they had been reading for hours. The room was quiet. His family had arranged themselves around him in the particular way that families learn in those rooms, close but not crowding, still but not absent, holding the specific patience of people who have accepted that there is nothing more to do and have stayed anyway. Victor had not spoken coherently in weeks. His brain scans, which his physician Scott Haig had reviewed carefully and more than once, showed tumor infiltration extensive enough that the cognitive function those scans described should have been absent. And then Victor opened his eyes and looked at his family and began to speak. Haig described the moment in an account published in Time magazine, a first-person clinical record from an orthopedic surgeon who had spent years working with patients at the end of life, and who wrote the account not as a man reaching for meaning, but as a physician reporting something he had witnessed and could not account for. Victor recognized each person in the room. He spoke to them by name. He engaged in a conversation that was coherent, purposeful, and warm. The conversation of a man who knew where he was and who was with him and what he wanted to say before the time he had left ran out. Then he lapsed back into unconsciousness, and he died. What Haig found himself returning to in his account was not the emotion of the room, though the emotion of the room was considerable. What he returned to was the scan on the wall, the imaging that had shown him, In the weeks before, a brain in a state that did not support what he had just watched happen. The tumor was extensive. The infiltration was documented, measured, confirmed by more than one set of eyes. The clinical picture had been clear. And then Victor had been clearer than the clinical picture allowed for, and the account of it was sitting on Haig's desk when he sat down to write, and the scan was still on the wall, and the two things had not resolved into a single explanation by the time the account went to print. The palliative care nursing literature had been receiving accounts like this for years before Haig's piece appeared in a general interest magazine and placed one specific case in front of a wide readership. Peer-reviewed publications in the Journal of Palliative Medicine and the International Journal of Palliative Nursing carried qualitative reports from nurses who worked in end-of-life settings, professionals accustomed to the final stages of illness, familiar with the ordinary fluctuations and the plateau silences of advanced disease, and therefore in a position to distinguish between what they had come to expect and what they had not expected at all. The accounts in those publications described patients who had been uncommunicative for months. They described patients who, in the space of a single afternoon or evening, had spoken clearly, asked for family members by name, expressed specific wishes, and then returned to silence. A nurse writing in her clinical log about a patient who had not responded to her name in 4 months, suddenly asking for water and thanking her by her first name, is writing down a deviation from an established baseline. The baseline is the point. It is what makes the account clinical rather than anecdotal. These were not patients who had been showing some signs of occasional awareness. These were patients whose charts showed long runs of nonverbal, unresponsive status, days becoming weeks becoming months, with the single event noted, dated, described, and filed as though the nurse was not entirely certain what file it belonged to. What the nursing literature established, carefully and over time, was not an explanation. It established a pattern. The pattern was the same one that appeared in physician accounts and in family testimony, and in the historical medical record, going back considerably further than the modern case literature. The same features recurring in different countries and different clinical settings and different disease contexts, reported by different categories of observer working independently of one another. Sudden emergence from a long plateau of silence. Recognition of people the patient had not appeared to recognize in months or years. Purposeful speech. Expressions of love or farewell. Rapid decline afterward. Death within hours. Maggie Callanan had been collecting versions of this pattern since the late 1980s. A hospice nurse with decades of direct clinical work behind her, Callanan co-authored a book in 1992 called Final Gifts, which drew on years of direct testimony from hospice workers describing the communications and behaviors of patients in their final hours and days. The book was not written as a research document. It was written as a practitioner's account, the kind of record that a person makes when they have been in enough rooms, at enough bedsides, across enough years, to start seeing the shape of something that the formal literature had not yet fully described. What the hospice workers Callanan interviewed described, in careful and unhurried detail, were patients who arrived at clarity at the very end, patients who spoke from silence, patients who said things that their families had not expected to hear again. Callanan's work arrived in a period before the phenomenon had a formal clinical name, before Nam and Grayson had organized the historical case literature into a published survey with numbered entries and condition categories. The hospice nurses and social workers and physicians she spoke with were working from observation rather than from a defined research framework. They were describing what they had seen, the consistency of what they described, across different institutions, different patient populations, different stages of different diseases, is part of what later researchers drew on when they began to build the formal literature that would give the phenomenon a name and a place in peer-reviewed publication. Alexander Batyani was working in Vienna at the International Academy of Philosophy in Liechtenstein when he began the systematic survey work that would become the most comprehensive attempt yet made to quantify how commonly terminal lucidity is observed by healthcare professionals. The project was methodical. Batyani and his colleagues developed standardized interview protocols and a structured survey instrument, and they brought it to approximately 800 healthcare professionals, nurses, physicians, palliative care specialists, social workers, people who worked in clinical settings where they would have had the opportunity to witness what the survey was asking about. The result of that survey, published in 2018, was not a collection of dramatic individual cases. It was a proportion. Roughly 80% of the approximately 800 healthcare professionals surveyed reported having personally witnessed at least one episode of unexpected mental clarity in a severely cognitively impaired patient near the end of life. 80%. The number is large enough that it reframes the question slightly, not whether terminal lucidity occurs, but why it does not appear more frequently in the formal clinical literature, given how often it is apparently being seen. Batyani's reading of that gap was that the episodes were being witnessed, absorbed into the ordinary experience of end-of-life care, and not formally documented because there was no established protocol for documenting them, no category on the standard chart that quite fit what had happened. The ward nurse who pauses outside a door because she hears a voice she did not expect to hear is not reaching for a pen in that moment. She is standing still. She is listening. The sound of a voice she knows has been absent for months or years is something that lands before the clinical response does, before the documentation instinct does, before the trained professional habits organize themselves into an appropriate response to an anomalous observation. By the time the response organizes itself, the episode may already be ending, the voice may already be fading, the patient may already be returning to the plateau of silence that preceded it. That gap between the witnessed event and the documented account is part of what Batyani's survey was designed to measure. The gap is not evidence of carelessness. It is the expected product of a clinical environment that was not built to capture spontaneous, brief, unrepeatable events in patients whose condition had been considered stable and whose trajectory had been considered clear. The hospice chart has columns for vital signs and medication administration and pain assessment. It does not have a column for the return of a voice that had been absent for 3 years. The structured family interview forms that Batyani and his colleagues developed as part of their research methodology were an attempt to reach around that gap, to collect testimony from the people who were in the room when the episode occurred, using a standardized set of questions that would allow for comparison across accounts. The forms asked about the nature of the patient's prior impairment, the duration of the impairment, the content of the lucid episode, the patient's apparent level of awareness and recognition, the duration of the episode, and what followed it. The accounts that came back through those forms from families in different countries describing episodes involving different patients with different conditions described the same thing. The patient recognized the people in the room. The patient spoke clearly. The patient asked for someone who was not present, or expressed something that had been unsaid, or spoke to the room with a quality of attention and presence that the family had not seen in a long time, in some cases had not seen in years, in some cases had not seen for so long that the family members answering the questionnaire were describing a person they had, in some sense begun to mourn before the death occurred. And then the episode ended, and the patient died, in most cases within hours. Scott Haig had used a particular word in his account of Victor. He had written that Victor was in those final hours of clarity, more present than the clinical record had any explanation for. The word present carries more weight in a palliative care context than it does elsewhere. In those settings, presence is precisely what the illness takes away: the availability of a person to the room they are in, to the people around them, to their own experience of being somewhere. Advanced dementia takes it. Brain tumor infiltration takes it. The strokes and the infections and the long progressive diseases take it, each in their own way and at their own pace, until the person in the bed is there in a physical sense and somewhere else in every other sense that matters. And then, in these documented cases, they return. Victor returned for long enough to say goodbye. The hospice patients in the palliative nursing literature returned long enough to ask for their sister by name, or to tell the nurse she had been kind, or to hold their daughter's hand and ask about the grandchildren. The patient in the family interview form on Bathiane's desk returned long enough to say the thing that needed to be said, and then went back. The accounts across the formal literature are not identical, but they share that quality of purposefulness, a sense reported consistently by witnesses that the clarity had an aim, that the voice that came back for something specific. The researcher reading those accounts is working with testimony, not with imaging data or biochemical markers. The testimony is all there is: the family interview form, the nurse's clinical note, the physician's account in a medical journal or a general interest magazine. What the testimony records is what witnesses observed, and what witnesses remember, and what witnesses understood themselves to have been in the presence of. It is evidence of an experience. It is not in itself an explanation of a mechanism. That distinction matters, and the researchers working in this field make it carefully. Bathiane was careful about it. Nam and Grayson were careful about it in 2009. The nursing researchers whose peer-reviewed work appeared in the palliative care journals were careful about it. The phenomenon is documented. The mechanism is not established. The distance between those two statements is not a small distance, and it has not been closed by the weight of testimony, because testimony, however consistent, however carefully collected, however widely distributed across countries and decades and clinical contexts, is a record of what was witnessed, not a record of what caused what was witnessed. That care in the framing is not hedging. It is the appropriate response to a situation in which the evidence points clearly in one direction, the direction of a real, recurring, well-documented phenomenon, and stops pointing at the point where explanation would need to begin. What terminal lucidity is has been established clearly enough that researchers are no longer debating its existence. What terminal lucidity means, in the mechanistic sense, remains genuinely open. The scan on the wall behind Victor's bed has not been explained. The chart with 60 days of nonverbal notation and the single handwritten entry at the end has not been explained. The survey responses from 800 healthcare professionals, the long column of yes entries on Bathiane's screen, have established frequency without establishing cause. In Vienna, on a desk in a research office, a manila folder sits open. The folder contains a structured family interview form. The description field on the form has been filled in by hand. Careful, unhurried handwriting, the kind of handwriting of someone who sat with the account for a while before committing it to paper. The account describes a person who had not spoken in years. The account describes a room in the evening and a family arranged around a bed. and then a voice. The account describes what the voice said. It describes how long it lasted. It describes what happened after it ended. The pen rests across the top corner of the form, where it was set down when the account was finished. The file is open because the account is complete, but the question is not. The handwriting records what happened in the room. What the handwriting does not record, because the person who wrote it did not know, and the researcher reading it does not know, and the literature in which it will eventually appear does not establish, is what permitted the voice to come back. What opened in the brain, or in whatever it is the brain is doing in those final hours, that allowed the room to be present again, and the people in it to be recognized, and the words to arrive that had been absent for so long. The form is the record, and the record is specific and careful and consistent with hundreds of other records collected from other families in other cities describing other rooms. The consistency is the thing that the research has been slowly, carefully establishing across decades, that these are not rare and isolated aberrations, not the particular hallucinations of particular families under particular kinds of grief, but a pattern that was noticed by physicians in the early 19th century and written down in careful German script that survived into the archive. A pattern that hospice nurses were describing to Callanan in the late 1980s at kitchen tables with tape recorders between them. A pattern that showed up in 800 survey responses as something the majority of experienced end-of-life care professionals had witnessed personally. A pattern, which is to say, something that happens. Something that keeps happening has kept happening across conditions and countries and centuries of independent medical witness. Something that is not explained by the ordinary mechanisms of disease fluctuation, not medication changes, not hydration levels, not time of day, not the ordinary variance of a condition course, because it occurs in patients whose decline has been severe and stable and long enough that those ordinary mechanisms have long since ceased to account for the range of what is being seen. Something that arrives and then departs in the hours before the end. The nurse who hears a voice behind the closed door of a patient whose chart she last marked as nonverbal 3 months ago is not making a clinical error when she stops in the corridor and stands still for a moment. She is not misreading the situation. She is recognizing it. She has perhaps seen it before, if she has worked in end-of-life care for any significant length of time, and Bathiani's survey proportions are accurate. She has almost certainly seen something like it before. She stands still because the voice is clear, because clarity in a room where it has been absent for months has a quality that stops the person who hears it before any other response has time to form. She will write it down. She will date it and time it and note the content as best she can and add it to the chart where it will sit beside the long record of absence that preceded it, and the chart will go into the file, and the file will eventually reach a researcher who is building a database of accounts, adding each one to the growing count. Another yes in the column, another entry in the numbered table, another handwritten line at the end of a long run of standard notation. The cases accumulate, the way all cases accumulate when something is being documented carefully over time, not because each case resolves the question, but because the accumulation of cases with consistent features across independent contexts is itself a form of evidence. The kind of evidence that says something is happening here, even before the question of what and why and how has been addressed. 83 cases in the 2009 survey, 800 professionals surveyed in 2018, 80% of whom said yes. The nursing journals and the physician accounts and the family interview forms in the open manila folders on the research desks in Vienna and elsewhere. Victor's scan is still on the wall in the memory of the account. The tumor is still there in the imaging, extensive and documented and measured. Victor is still described in Haig's account as more present in those final hours than the scan should have allowed. The account has been published. The scan has been reviewed. The two things have not resolved into each other in the years since the account appeared. They remain what they were in the room in 2007, a witnessed event and a piece of imaging that does not explain it, sitting alongside each other in the record. The record is what remains. The testimony of the nurses and the physicians and the families who were in the room, the handwriting on the interview forms, the case entries in the published surveys, the pen resting on the top of the open folder, the account of the voice in the room, the recognition in the eyes, the words that arrived after months or years of absence, the farewell that was given before the final quiet. What happens in the brain in those hours is still the open question. The hypotheses have been offered and examined and found to be incomplete, not wrong necessarily, but not sufficient to close the distance between what the imaging shows and what the witnesses report. The research continues. The cases continue to arrive on Bathine's desk, and in the palliative nursing journals, and in the accounts of physicians who have been in those rooms and have written down what they saw because they could not do otherwise, because what they saw required a record, because the record is the only thing that persists after the voice has gone quiet. In the family interview form in the open folder, the description field ends mid-page. The rest of the page is blank. The handwriting stops where the account stops, at the point where what could be described has been described, and what remains is the silence that followed, the voice, the room after the conversation ended, the monitors continuing their unchanged rhythm, the family still arranged around the bed, the person they had been listening to, no longer there in the way they had been there, for those few clear hours, the window still showing whatever light was left in the day. The form records the return of the voice. It does not record what the silence after the voice was like, because that is not what the form is for. The form is for the documented account of the event. The silence after the event belongs to the family, and to the room, and to the particular quality of the hours that followed, the particular weight of a silence that comes after a voice returns unexpectedly and then is gone again, this time for good, this time into the final stillness that the medical chart will record in its own way, with its own notation, at its own time. The pen rests on the corner of the form. The folder is open on the desk. Outside the research office in Vienna, the city is continuing its ordinary evening. The cases are filed in a drawer beside the desk, each one its own account of a room at the edge of things, a voice returning from long silence, a person briefly and fully present in the hours before the end. The accounts are specific and careful and consistent. The question they point toward is still open, and somewhere tonight, in a hospice room, in a city whose name does not appear in any file, the light from the hallway falls through a half-open door onto a bed where someone has not spoken in a very long time. The family has arranged themselves the way families learn to arrange themselves in those rooms.